Well, thank you guys so much for joining us today. I have members of Alchemy with us today, Sarah, Will, and Peter, and they will be talking to us today about pitfalls to avoid when setting up your 340B in-house pharmacy. If you have any questions as we go along, please feel free to unmute yourself, or you do have a chat box. That option should be on the upper right-hand portion of your screen. So you should be able to click on that, open up the chat box, and answer or ask any questions that you may have. But with that, I will turn that over to our speakers, and they're going to teach us something today. Thank you so much for joining us.
Right. Thank you, Laura. Thanks to everybody for joining. As Laura said, this presentation, this webinar's subject is pitfalls to avoid when setting up a 340B in-house pharmacy. It's the only thing that we do as Alchemy, which is why we are here today. So our company, a little bit about us, we were started in 2023. Relatively new in the market, but the fastest growing 340B managed pharmacy provider, I would say, in the market. Alchemy builds and operates entity-owned 340B retail pharmacies across the country. It's the only thing that we do, which is an entity-owned model where a covered entity owns the pharmacy, and we help with the setup, the deployment, best practice, compliance, and operations, as well as layer in the technological innovations that will help covered entities do more with less, expand patient reach, and ultimately expand patient impact. And we all know how important the 340B program is for every covered entity that serves underrepresented or risk populations. And our view has always been that the most foundational piece of your 340B program should start with your entity-owned in-house pharmacy, because it's the most durable part of the law to be able to withstand and weather any regulatory uncertainties as they come up in the future. So it's a pleasure to be here. We are working with 26 covered entity partners throughout the United States in 15 states, and have been growing at about 20% month-on-month clip on medications dispensed in 2025. Sarah, if you can go to the next slide. And a little bit about myself. My name is Peter Park. I'm one of the three presenters here today, and I'm one of the three co-founders of the company. My other co-founders here are Sid and Susie. Sid is a three-time founder as well. His prior company, if you've heard of TruePill, or if you've heard of brands such as Mark Cuban, Cost Plus Drugs, TruePill was the company that under the hood that made those types of pharmacy innovations possible. So any digital health brand, any sort of pharmacy delivered to your door, that was probably TruePill under the hood that was delivering all those services. Susie Crow is a PharmD MPH, left an academic tenure track position at East Tennessee State University to work and build Alchemy together as a co-founder. She comes from a public health background as well as a pharmacy background, and is widely published and really wants to work directly in service with covered entities and safety net clinics, because she, from her background, came up through the same types of systems that have impacted her life and her family. We're on a service and on a mission to serve covered entities because this is our life's work. For myself, I come from an HIV care background. I'm kind of a business guy that works in public health, and did most of my training and learning with an academic medical partnership of U.S. universities that collectively stood up the largest HIV clinic in the world in East Africa. So that's my background. I'll turn it over to Will to give an introduction of himself, and then Sarah, and then we can dive into the slides from there.
Awesome. Thank you so much, Peter. Hey, everyone. My name is Will Hollingsworth. I'm the head of pharmacy strategy and operations here at Alchemy. I was one of the earliest employees here, joined when we were just 5 people, and have been here ever since. Have been able to kind of grow alongside the company, have helped build most of our pharmacies, both from the construction piece all the way through launch, and then ramping kind of other kind of critical access programs, ranging from mobile van medication units, insurance enrollment programs, and more recently, food as medicine programming as well. I'll hand it off to Sarah.
Thanks, everyone. Good morning. Sarah Peasley. I am Alchemy's VP of Growth, so I support on the business development and partnership side, as well as marketing. My background is largely in primary care access for rural and hard to reach populations, both here in the US and across Africa earlier in my career. Before we move on, I think, we want to make sure that this webinar is as useful to you all as possible. So I'm going to put a couple of questions into the chat to get a sense of kind of where you are, where your hospitals are in terms of your process to launch a 340B in-house pharmacy. Are you exploring? Are you actively in the process of doing so? Kind of that'll be helpful to ground kind of what we share, and then one thing that you're hoping to get out of the webinar. So I'll put those in the chat, and please please write any responses, and that'll be great context for us. Great. I'll give that a minute, and for any responses in the chat, and I'll continue to monitor it over the next few minutes, so we can always jump in if there are questions. But with that, we'll jump into some of the pitfalls that we see commonly with many of our in-house pharmacy partners.
Awesome. Yeah, we'll jump into kind of what it actually means to ramp a pharmacy. I wanted to start by just emphasizing that ramp in and of itself is more of a strategy and is not just an outcome that we should be chasing as an organization or as a new pharmacy. It's really important that we decide kind of what patients we're going to move first and why. And if you don't, then you do risk disrupting patient care, creating some kind of community blowback, or potentially ruining any of the ROI assumptions that you had made when you originally launched the pharmacy. As many of you know, Arkansas has more kind of rural dynamics than many states, and so the independent local pharmacies really can be a critical access infrastructure for patients to be able to get their medications. And winning isn't just maximizing capture rate at any cost, but instead is sustainable and kind of how do you build a sustainable access and trust within your communities. Really, really important to make sure that we build alongside any community pharmacies in the area. When you are first launching your pharmacy, it's important to start by mapping what your local ecosystem might look like. Who are the nearest independents? What do they do really well, whether that be delivery courier, relationships with patients, or kind of off hours, where do patients rely on these pharmacies the most, and then decide very intentionally what you will and won't build from day one. We've had a couple of pharmacies ourselves that we're trying to transition some of their HIV and Ryan White patients over into the pharmacy, and decided to actually not transition any patients until they came in person, not only to have get a new prescription, but have a conversation with both the pharmacist and new prescriber about what that combination of care might look like. This helped protect continuity of therapy, as well as avoiding any confusion and patient drop-offs. We had another pharmacy that was very intentional around actually absorbing some of the money-losing prescriptions, and so that the local retail pharmacy did not have to worry about taking on the entire kind of financial force of some of the worst economic drugs in a retail setting. And so these are just some of the things that we want to start thinking about as we are focusing on preserving those local pharmacies. Sometimes the best long-term move is actually leaving some of the volume on the table and potentially some of that value, so that the community doesn't have any type of revolt against the pharmacy, or there isn't any blowback or potential shutdowns of those really community critical access medication programs down the road. In terms of how we start to think about how to actually ramp the pharmacy and what those phases could look like, typically I break this down into 3 different options that we could start with. First, as your kind of lowest friction patients, this might be your employees, your out-of-state contract pharmacies, your mail order pharmacies, typically the patient base that would be the easiest to transition and easiest to have those conversations with, where the patient experience might not be that altered. Secondly, we could consider ramping the clinical complexity first. These would be your patients with 4 to 5 or more medications, where having some type of clinical integration between the provider and the pharmacy would have an incredibly good impact on the patients. We can introduce things like medication sync, adherence regimens, and other kind of high-touch pharmacist interventions to strengthen that pharmacist to physician loop, and it will help you build clinical credibility. And then finally, if you are focused on the fastest ROI for your pharmacy, making sure to drive kind of the high value, high margin 340B opportunities to that pharmacy first. This is, only if you feel that you're ready, both from an operational and a patient experience perspective. Otherwise, there are other risks that could be induced here as well. RAMP isn't just about volume, but it's also about operational complexity. And any new segment that you decide to start ramping, whether that be a new location, introducing shipping, courier, or a new patient type, is potentially a new operational process that you need to think through prior to bringing those patients in-house. In terms of the general sequencing that we have listed here, we have employees, out-of-state contract pharmacies, closed door, and then that high value or high volume patients later. Really starting with the employees allows you to have a safe testing bed for the new pharmacy, get down all of the critical operational components. The out-of-state contract pharmacies will be less locally sensitive for the local independent pharmacies, as well as less politically sensitive. And then the closed door pharmacies allows you for some controlled workflows, and then you can move into those high value and high volume down the road once you are confident that you can execute without disrupting any patient care. In terms of the ROI model specifically, this is really important to think through things like what is the ramp schedule segment by segment, addressing any kind of script volume by service line, whether that be courier, delivery, other location pickup, or pickup in-house at your pharmacy, and then understanding kind of the incremental operational expense by each phase, thinking about staffing, support hours, any kind of working capital and inventory timing that we'll touch on later as well. In short, this is just something that we must think about in phases. Don't tie yourself to a specific capture rate, and really build that ROI model for your ramp based on your specific situation and patient base. Go to the next slide. In terms of one of the things we had touched on for that ramp process, having a mail order and delivery system is no longer optional, but is really a requirement for most patients from a patient experience these days. If you don't meet the modern retail expectations with delivery, texting, easy payment links for patients, you will lose patients and erode trust within the community. And if you don't do delivery without the right workflows, you'll induce compliance and operational risk that could shut the entire pharmacy down if not handled carefully. Patients will innately compare you to, not just in this setting, not just the local retail pharmacies, but your CVS's, Walgreens, Amazons, and things of that nature. And so incredibly important to understand where the bar is, having delivery options, proactive updates on the status of where those medications might be, easy refills, easy signature and payment responses, as well as any type of support that might be needed in those more remote environments. Patients aren't going to grade you on intent, but instead are going to look at what is the overall experience and how does that compare to their other options on the market. In terms of what those delivery workflows might look like, delivery, you do need to introduce things like proof of delivery and consent documentation, things such as privacy considerations around both texting for HIPAA and notifications that come through all those patients, but as well with any kind of packaging considerations, how to handle failed delivery, reshipments, or exception handling if there's any cold storage or cold chain needed for certain medications, as well as any additional policies and procedures around controlled substances specifically, and making sure that we always get patient consent prior to mailing those medications. All of these things, we have a kind of small photo shown here, but in terms of getting payments from from patients, collecting signatures, all the policy and procedures that would be needed, as well as that medication shipment tracking features and understanding the proof of delivery. That is all handled within the Alchemy app that we have kind of some of those signature workflows and tracking workflows shown here. But dependent on medication class and patient preference, you may allow, delivery as well with the appropriate consent and privacy protections. But you just need to make sure that you do have documented proof of consent for those delivery type approaches. Another type of delivery that is important to have on top of mail order for many patients would be a courier delivery. This would be where you get a courier or driver to actually hand off those medications directly to patients. This is another workflow that is supported within our platform. This is super important as many patients might not want those medications dropped directly at their doorstep, as it does allow for some type of another family member or a friend potentially opening up that package, and then removes the kind of right to privacy that all patients should have for their medications. In terms of off hours support, this is something that is incredibly important. What we found is the kind of the easiest times to reach patients are typically outside of a traditional 9 to 5. And so making sure that, if a patient has delivery or payment issues, if there are medication questions directly to the pharmacist in those remote settings, that patients do have the ability to reach out to someone and have the right workflows that they can get their questions answered whenever that patient is available in these more remote settings. And then, as I had mentioned earlier, just to close out here, the kind of text to pay and remote copay collections aspect of delivery approaches is incredibly important. This is something that we have built out internally, but if you guys decide to kind of take this on yourselves, making sure that you have the right payment infrastructure, reconciliation of those payments, as well as any kind of fraud or chargeback handling, that is built into the copayment collection workflows as well.
Maybe I'll just jump in with one thing, is that, doing, as it says at the top, kind of doing mail order and delivery compliantly is very challenging. And it was one of the main reasons Alchemy decided to create our own kind of digital app that works with pharmacy management system. We didn't see any off-the-shelf pharmacy management system that really supported a mail order and delivery, signature collection, and all the compliance needed for PBM and other audits sufficiently. And that really came from kind of Sid's background at TruePill doing mail order at scale. So definitely something to be thinking about, as Will went into more detail.
Or let's say there are off-the-shelf solutions that are there, but the patient experience and the friction there is so high that it ultimately will drive down your capture rate. So I think it's this issue. Capture rate is really a function of trust and patient experience. If the patient experience and the trust in the pharmacy is there, and the convenience factor is there, and the ability to ask questions and get support off hours after work, the way that Will had mentioned, those are all drivers for what ultimately is really what capture rate is about, which is that your pharmacy is a better solution than what else is out there on the market. But compliance is non-negotiable. And so this is one of the things where you want to smooth out all of the friction, keep compliance levels at the highest possible standard, but do it in a way where patients can actually increase their patient satisfaction with the pharmacy provider versus lower it. And that's kind of what we've seen from the off-the-shelf solutions, is that it makes that trade-off in a way where it kind of settles down to where pharmacies are like, well, we can only get a 10% capture rate. We reject that on the grounds that if you improve the patient experience and do so compliantly under the hood, then you will be able to improve that capture rate number.
Yeah, I appreciate the extra bullet points there. You will get audited whether you do mail or not, and it is really important to be able to track down every step of where each of those medications went along the entire value chain. If they stopped or got lost somewhere in UPS or another courier service, you need to be able to track kind of every independent step throughout that process to prove chain of value, and that you understood that those medications got directly into patients' hands. So I appreciate the emphasis on that, Peter and Sarah. moving into what you can actually do and how to think about specialty license and what you're able to do with a traditional retail license. A lot of clinic teams and pharmacy teams, when we first talk to them, do confuse kind of additional licensure with specialty access. And so the retail license from the Board of Pharmacy usually is not the bottleneck, but instead, a lot of the times it's the PBM and manufacturer access, accreditation, and kind of operational capabilities that they require for a lot of these limited distribution drugs. In terms of what you can dispense on a retail license, it is almost everything, with a handful of exceptions. The retail license from the Board of Pharmacy usually tells you kind of what you're allowed to dispense, and then specialty access, as I said, is more of that PBM and manufacturers restrictions and reimbursements. You can launch and dispense most things with a traditional retail license as you're kind of building out your specialty access program in parallel. For things like some specialty type of medications that you can dispense, things like hepatitis C antivirals, many oral oncology medications, as well as most autoimmune biologics can be dispensed on a traditional retail license. And we have dispensed all of those in pharmacies that maybe haven't sought those type of specialty accreditations. Some categories, I do want to point out some categories such as like sterile compounding, certain infusion related services, and some nuclear medications. Those are different and do require some additional licensure as well as certification. But for the most part, most standard medications, that retail license should be enough to kind of get you started. In terms of actually what the URAC is, for those that are not familiar, this stands for the Utilization Review Accreditation Commission. Think of this as kind of the specialty pharmacy accreditation for your PBM networks, manufacturer programs, and limited distribution drug access programs. The URAC typically focuses on quality management programming, patient management and adherence workflows, clinical documentation, and operational consistency and reporting. And so URAC doesn't make you a specialty pharmacy out of nowhere, but it is the accreditation that most manufacturers and PBM networks look at to prove that you can run these specialty workflows reliably. In terms of LDD, this stands for your limited distribution drugs. And so typically, as you kind of look to get your URAC accreditation, manufacturers can still restrict, depending on which drugs they are, to a limited set of pharmacies. Usually, manufacturers will do this due to handling complexity, their own kind of data and reporting requirements, as well as any type of patient support and financial access integration. We very commonly with some oncology medications, as well as some stem cell biologics and things of that nature, as well as a handful of other medications. But this is not something that you need to get accredited and in network with all LDDs, but instead really important to look at your prescribers' patterns, what drugs are being written that might qualify under an LDD, identify those target drugs based on the patterns that you're seeing, and then you can build out kind of the operational proof that you would need in order to get that certification and get in network with those manufacturers, whether that be building out cold chain SOPs, tracking adherence and outreach cadence, documenting reporting capabilities, as well as any patient support workflows. And we do suggest getting that retail license in parallel with your any other licensure for the Board of Pharmacy. Don't let that specialty license become the reason that you delay launching a pharmacy ever, but instead, launch what you can today, and then we can build access for all of these harder to reach, harder to access medications in parallel of launching the pharmacy and getting your patients access because of all of the operational hurdles that will be induced. And that is, we'll hand it off to Peter to talk about some of the financial impacts and cash flow related concerns.
Sure. Thanks, Will. Next pitfall, and again, if you guys have questions along the way, please feel free to chat them in, and we can address them like while we're talking or at the end of the presentation as well. The next pitfall we wanted to call out is not considering the inventory related cash flow impacts. I think the other thing to say is that also to be so intimidated by the inventory related cash flow impacts that it delays a start. But I think you do need to have the complexity in the pharmacy is not in the profit and loss statement. It's actually in the cash flow statement side of the unit of the service unit. And the upfront cost of setting up a pharmacy is much lower than the ongoing inventory related purchase requirements. So after you start your pharmacy and get it launched, you'll be purchasing medications. We always hold a very lean inventory model where there is not a lot of several days or weeks of inventory on the shelves, because there's pretty good day ahead ordering processes with McKesson and Cardinal and all the major wholesalers. But even so, when you're purchasing, you need to purchase the medications, dispense them, and especially on a new start of a pharmacy, it will take a little bit longer for CVS Caremark to pay you for the first dispenses. As you're ramping up the program, you could have a problem where you're kind of growing too fast, where you've dispensed a lot of medications. In other words, by purchasing inventories that are due, let's say 14 days out or 21 days out, where you have to pay the wholesalers. And then the PBMs will not reimburse for a certain period of time in excess of 30 days, 40 days, or 45 days for the initial few months of launch. So in that interim period, you still need to serve patients, dispense medications, but the cash draws on the account is going to be heavy from a working capital standpoint. In other words, the drug inventory standpoint. And having the ability to have a line of credit or have enough of a balance sheet to ride through that initial period is the most challenging part of the business from a financial perspective. That said, you need to have a system to navigate these uncertainties. But we do, and there's a number, and you could work with your local lender or other sorts of partners or internally to be able to have the cash flow available. But when you ride through that initial part of the process, what we've seen is that the in-house pharmacy then becomes the cash generator for the rest of the operations of the hospital or the covered entity. The importance of having a financial strategy that manages the cash flow impacts, however, are even more important now than they were even 2 years ago. One, because of rebate models that I'm sure many of you guys have heard about in the news. The MFP rebate program that's going into effect, and general compression on 340B economics from MFP pricing lowering the cost of the spread on the 340B drugs. All of this increases the complexity of managing the cash conversion cycle or the working capital aspects of the business. And it is navigable, but it is something that you generally don't want to go through alone unless you have a very large balance sheet. I'll give some examples for small, like a small to mid-sized FQHC, which is smaller than many hospital-related pharmacies. The inventory, the cash flow impacts can be as much as $500,000 to $750,000 of reserves that you need to have on hand. But by month 5 from the commencement of operations, you will see that cash conversion cycle start to come into effect, where you're able to self-fund with a much smaller line of credit to ride through the ups and downs of the cash flow. I think, Sarah, you can go to the next slide. The other one is going it alone. Many hospitals are asking their inpatient pharmacy directors to manage their retail pharmacy. It's a totally different enterprise, and it does deserve its own standalone team to do this well. As Will had mentioned on mail order and courier delivery, the economics of 340B work out in such a way that your retail pharmacy economics are able to support extra wrapper services. And those extra wrapper services are what's going to have your pharmacy resonate with your patients, improve capture rate, and improve the standing of the pharmacy in the community as a site of care for your community. That said, the operational complexity is much higher than and is sufficiently high enough that having an internal team take that on as a second job, we've seen becomes like quite a large stretch, right? So if you do the upfront financial planning in the beginning, staff up and have your team dedicated to the retail pharmacy effort, then you will see that you can be able to get the ROI, the patient impact, the ramp, the capture rate that will become best in class. But it's not a side job or an extra job or an additional set of duties on top of your existing team. In terms of going it alone from an internal standpoint, there's also from the setup side, most people didn't go to pharmacy school to do ROI analyses and understand PBM contracts and what the mail order versus retail thresholds are by PBM, running those reviews, thinking about all those, the compliance and the business of running pharmacy. So getting support to do the due diligence, the ROI analysis, the ramp planning components, so it works with your broader contract pharmacy and community pharmacy networks. The applications where the stakes are quite high to submit an application the right way, in that the cost of delay can really impact the financials of your pharmacy, where you are now sitting on W-2 employees of your pharmacist in charge, and then you need to rewrite or rerun your CVS Caremark application. That can be a really big impact. And so it's really important to do it right the first time. And that's where it is helpful to have support. So you're not having to go through it alone and kind of figure it out and learn on the job. A couple of things on vendor models for partner models. We've seen like kind of two sort of themes. One is just as an advisor, there's a number that are out there that provide essentially the advisory support, fixed fee upfront. It's really like a consultant, not non-operational, and there's varying degrees of how much in the weeds that the advisor will provide from a support line standpoint, and that's generally fixed fee upfront. And then the entity-owned pharmacy and their team is fully responsible for the ongoing management with some lightweight support from there. And then the other is like a turnkey setup where there is no upfront fee, often set up on a portion of revenue or on a dispense fee basis, where it effectively turns out to be a portion of revenue. That is much more holistic, where it provides some partners provide the credit line and the financial strategy, as well as the business advisory, as well as the ongoing compliance support, and are kind of on the hook to make sure that compliance is part of the ongoing scope of work for and on behalf of the covered entity partner. You can go to the next slide, Sarah. Last thing I would say from a pitfall standpoint is really waiting to get started. This is probably the biggest one from our perspective, where it'll point you to the second bullet, where we have a covered entity partner in a state where they're considering changing up the carve-in and carve-out rules, which will really impact the economics of the pharmacy. A lot of compression on Medicaid reimbursement, which is also going to provide more financial strain on the nonprofit. And the saving grace for that program has been their in-house pharmacy. And so like, this is just a quote from them, where it was like, we were going through a number of policy related impacts for their program. And they said, thank God we have our in-house pharmacy already. Thank God we made the decision a year ago to have that going, because that is how we're able to keep our staff retained. That's how we're able to ensure that patients have access to medications, where 2 pharmacies in the neighborhood closed down because of compression of retail economics for pharmacy. And there is a site of care and there is a pharmacy in what became a pharmacy desert. And the program is in financial good standing because of their in-house pharmacy program having been set up. Our view is that, especially now in 340B, there is a cost to indecision as much as a cost to make the wrong decision, if not more. Indecision is a decision in our view. And again, back to where the original intent for and the original rulemaking around the 340B program was around your single contract pharmacy or your entity-owned pharmacy. Entity-owned pharmacy is the most durable way to protect your program, as well as control for patient experience, as well as control your destiny for how you want to manage and build out your 340B program over time. So in many ways, especially now with shifting rebate rules, potentially the 340B program itself getting migrated into CMS, the reorganization of the 340B program under HRSA and AHA. These are all speculative signals that are not proven out, but we do know that there is more volatility in the market. And we also know that the one part of the 340B program that is broadly accepted is going to be the entity-owned pharmacy model. So our view is to get started, at least on the build, get started on for at least a line, like a commitment on the ground where there's a subset, at least, of the patients that makes sense to bring into your holistic care services with the pharmacy. The way Will had mentioned at the top on the ramp side, to kind of be thoughtful about what patients you want to serve, and look at that from a financial perspective that is financially self-sustaining. Look at the scenario analysis around how that can impact your cash flow. And generally what we see is that the economics and the decision to go forward is the right one to build out your in-house pharmacy program. It is kind of, as long as hospitals, as long as any covered entity relies on 340B for the overall economics of their program, and the way that they're going to manage and ride through compression and other in reimbursement and in other aspects of government programs, this is a program that needs to be stood up. And so the right partner can help you kind of cut through the noise from an advisory perspective or a management perspective, take risk on some of the outcomes in case it turns out to be the wrong decision, to find the right partner that's willing to take that risk on with you and be a true partner. And ultimately, because these programs do take time to set up, you do need to identify a space. You do need to staff up. You do need to get the licenses and permits in hand to be able to get your pharmacy launched and get a network with PBMs. The working through the analysis up front and then working through the project plan in phase 2, generally what we've seen is that a lot of the uncertainty gets resolved over that period of time. And there has not been yet a decision that is not reversible in a way where the pharmacy itself isn't a part of the solution for given the way that the 340B program is and how central it has become for safety net providers throughout the United States. Let me pause there, and I don't know, Sarah or Will, if you guys have any other comments, or we can have some Q&A time from here.
No other comments on my end.
Thanks, everyone. Any questions or areas you'd like us to kind of dive into further on any of these pitfalls or other aspects? Happy to share our experience.
And we can also we kept this in general big themes, really, from what we've seen with our covered entity partners, what we've experienced as operators in the pharmacy space. But if there's specific 340B subject matter or any other things that were not thematically outlined in the slides as it pertains to the 340B program, in-house pharmacy, happy to have that discussion as well.
Great. Why don't we can take Beth's question from earlier around, more detail on the setup process and the kind of all that's included there. I can share a different slide, but perhaps, Will, you'd like to take that that question. Let me.
Yeah,
this is very high level, and we'll share more details. But
yeah, well, happy to, and thanks, Beth, for asking the question. Yeah, generally when thinking about setting up the pharmacy, First and foremost, as we have listed here, is going to be the physical setup of that pharmacy. So that's going to be any construction that's needed, any of the materials, shelving, things of that nature that might be needed for the pharmacy. At that point, you will need to start thinking about having a pharmacist in charge on site that will be able to actually be the pharmacist on paper for any of your licensing that comes in the future, as well as beginning to start thinking about this ROI model really at the onset as early as possible. If you need to set up any 340B combined purchasing agreements or things of that nature, we can start all of that in tangent with this physical setup and kind of credentialing piece, as well as making sure that any of the other HRSA registration windows, if you guys are opening up new locations, that everything is kind of, we have all of our ducks in a row. Once we move into the actual licensing, the very first piece that we'll get into is for the Board of Pharmacy licensing, quickly followed by DEA. We've seen Board of Pharmacy licensing in and of itself take anywhere from as little as 2 weeks to upwards of 2 months, sometimes even a little bit longer than that. Very state dependent, as well as time of year dependent on how busy the Board of Pharmacy is with credentialing the actual pharmacists, like specifically around graduation. That May, June, July time in the summer tends to get really busy in the Board of Pharmacy, and most states get pretty backed up. And then moving into the DEA licensing and permitting. DEA, we've seen turnarounds, again, very state dependent and even down to specific county dependent. We've seen turnarounds in as quick as just a couple of days and expanding upwards of 2 or 3 months here as well. So very dependent on your specific county and whatever DEA agent you get assigned. Throughout all of this process, you'll need to be thinking about hardware setup for these inspections, software setup for the inspections, any insurance like general or medical liability insurances that need to hit certain limits and things of that nature. Once you get through all of the kind of core setup with your Board of Pharmacy and your DEA, have your pharmacists in place, all of your policies and procedures created for the pharmacy, you can then actually begin getting some of the more PBM credentialing items in tandem. You can start applying for the NPI number, your NCPDP application. If you're going to contract with any PSAO that can help with the contracting with smaller PBMs, you can do this right after you get that DEA permit as well. And then applying for your state Medicaid, going through PTAN for your Medicare applications, as well as any wholesaler agreements, whether you're going to use a larger national wholesaler like McKesson or Cardinal, or moving into something that is more local to you and your pharmacy. Once you have your DEA, your Board of Pharmacy DEA, NPI, NCPDP, contracted with wholesalers, right around this time is then when you can finally start delivering on some of the initial cash pay prescriptions, and in tandem with that, begin the actual PBM applications for Express Scripts, Caremark, Optum, and any of the other PBMs that you want to get in network with. We've typically seen Optum be the fastest, somewhere around kind of the 7 to 14 business days. Express Scripts, in non-heat zones, Express Scripts kind of being right around that 2 to 4 week mark, and then Caremark typically being the longest of the 2 to 3 months. This is all non-heat zone specific. For those of you that are not familiar, heat zone is areas specifically that PBMs distinguish as high risk areas for fraud. These timelines can be double or triple to get PBM enrollments and in network with the PBMs if you do fall within a heat zone area. And so for any of you that have multi-site hospital systems, heavily recommended to think about heat zone considerations before you start the construction of the pharmacy as well.
Awesome. Thanks, Will. And, Alchemy's typical model is that Will and his team really manage this end to end. So everything from, the architectural designs, identifying a contractor if needed, but managing the contractor process and all of the construction, all the way through hiring and training the pharmacy staff, and then ongoing management. So certainly on any of these bullet points, Will can go into a ton more detail with any of you as relevant.
Yeah, and we'll add to that as well. Really, with our setup specifically, the kind of Alchemy's model of entity-owned, vendor-operated model, we very much see this as we are an extension of your team and your staff, and so we will, work with you in that same regard. We'll work very closely on what specifically works for your current teams that are in place, your current patient base, as well as giving all of the considerations and bringing everything to the table for you to then be the ultimate decision maker before actually making any go forward decisions there. So very much working collaboration with anything that you and your patient base and your employee base want to kind of see come to fruition throughout the implementation phase and build out phase to the credentialing phase, and then post launch if there's any specific financial programming, clinical programming, or otherwise operational programming that you guys want to start introducing as an extension of that pharmacy.
And with that, I will adjourn for today. I'll give you all back the rest of your afternoon. Thank you so much again to Peter, Will, and Sarah for joining us today, taking time out of their day and talk to us. And I will talk to you all later. Y'all have a good rest of your day.